Bonjour. I'm a palliative medicine consultant, clinical professor of palliative medicine at the Cumming School of Medicine, University of Calgary, and former president of the Canadian Society of Palliative Care Physicians, the national specialty society for palliative medicine in Canada. Legalizing euthanasia and assisted suicide has completely changed medicine and the practice of palliative care in Canada. There is not a day that goes by now that euthanasia does not occupy my time, and it has become increasingly difficult to be able to provide our unique expertise in palliative care to alleviate suffering. Many palliative care clinicians are exhausted and demoralized and are leaving or changing their practices. Today, I will share with you some of how euthanasia and assisted suicide is impacting the practice of palliative care in Canada. In the landmark Carter versus Canada ruling that paved the way for the federal euthanasia law, the Supreme Court of Canada discussed what possible impacts implementing a law for assisted death prior to securing universal access to palliative care might have on the development of a strong palliative care system. And ultimately, they suggested that the legalization of euthanasia could be leveraged to strengthen the development of palliative care services and improve access to high-quality palliative care. In the subsequent legislation, the Government of Canada positioned palliative care as a legal safeguard for euthanasia, requiring all patients requesting a medically administered death to have access to palliative care. Unfortunately, palliative care remains woefully underfunded and inaccessible to many who need it. Only about 30 to 50% of Canadians have access to some kind of palliative care of unknown quality, and very few, only about 15%, have access to specialist palliative care to address more complex issues. You are less likely to receive palliative care if you are poor, Indigenous, homeless, incarcerated, young, or live in a rural area. Health Canada's latest annual report on euthanasia consistently shows that just under 1 in 5 receiving an assisted death have no palliative care at all. And in addition, just over 1 in 5 received palliative care much too late, for less than 2 weeks prior to receiving euthanasia. This means that approximately 40% of those receiving euthanasia had little to no palliative care. This is consistent with a Canadian study by Monroe et al. In 2020 that showed 40% of patients in their area had no palliative care prior to requesting an assisted death. Palliative care experts and national palliative care organizations have expressed ongoing concern that continuing to expand euthanasia without investing in the necessary resources to support universal access to palliative care negatively impacts patients' outcomes. Tragically, we continue to see far too many patients in our practices who have opted for euthanasia due to lack of adequate palliative home care resources to remain in their homes or home communities. The deliberate use of the terminology in Canada of medical assistance in dying to refer to the practices of assisted suicide and euthanasia has also been problematic for palliative care, causing ongoing confusion between euthanasia and palliative care. National palliative care organizations advocated against the use of this euphemistic language, arguing that palliative care assists those who are dying to help them live as fully as possible until their natural death, but does not intentionally end life. Palliative care is a holistic approach to care that focuses on enhancing the quality of life for persons living with serious life-threatening illnesses and their families. Clinically, we do this by means of early identification, impeccable assessment, and treatment of symptoms, including physical, psychosocial, and spiritual concerns, to support a person in living well until they die, medical assistance in living, if you will. Palliative care is internationally recognized as a practice distinct from assisted suicide and euthanasia. In palliative care, we have worked for over 50 years to reassure patients, families, and healthcare providers that our therapies do not hasten death or shorten lives. For example, when we give them opioids to treat their symptoms or other medications to help people alleviate their suffering. Despite the clear distinction between palliative care and assisted death, some euthanasia proponents continue to push for euthanasia to be seen as part of the continuum of palliative care and refer to euthanasia as an extension of palliative care or as another tool in the palliative care basket. The Canadian Society of Palliative Care Physicians stated to the Canadian Parliament that, quote, conflating palliative care with assisted death ensures palliative care remains associated with end of life, and this has created unnecessary and unintended barriers to the integration and timely access of palliative care services that are needed early in the illness trajectory. We have now lived with legalized euthanasia for over 7 years in Canada, and the reality is that the assisted death law and its implementation have significantly damaged palliative care, including fewer palliative care resources, replacement of palliative care with assisted death practices, and increasing distress of palliative care clinicians. I'll provide some specific examples. Some health authorities have required euthanasia coordination to be incorporated into palliative and end-of-life care programs. This has led to palliative care nurses leaving their jobs as they were spending most of their time on euthanasia and felt unable to provide their expertise in palliative care. In Ontario, Canada's most populous province, doctors providing euthanasia must use palliative care codes to capture and bill for their assisted death provisions, despite strong advocacy against this from palliative care medical associations. Use of these palliative care codes then makes euthanasia providers eligible for a special premium meant to incentivize doctors to provide general level palliative care for their own patients. Clinicians are spending increasing amounts of their time on euthanasia referrals and eligibility assessments, taking them away from their time in palliative care. Clinicians are distressed and leaving the specialty, making the workforce crisis worse and decreasing the expert palliative care available to patients who need it. There is decreased access to specialized palliative care beds when health authorities require hospices and palliative care units to admit patients for the sole purposes of administering euthanasia or risk losing government funding. This has happened to many hospices and palliative care units in Canada. There are virtually no euthanasia-free spaces. We also see patients fearful of palliative care services because they associate or confuse it with medical assistance in dying, and are afraid that palliative care will hasten their death or euthanasia will be provided without their consent. Patients accessing euthanasia due to a lack of palliative care provision, patients requesting palliative care and the euthanasia team being sent instead, and patients requesting euthanasia because a trusted physician suggested it to them. I personally have met dozens of patients who told me that they requested an assisted death because a trusted doctor said they would be a good candidate for it, and they were scared that their symptoms would be very severe. As UK palliative medicine consultant and member of the House of Lords, Baroness Elora Finlay has stated, doctors have an inherent power differential in a consultation. Offering lethal drugs as a therapeutic option gives a subliminal message that what lies ahead is so awful you would be better off dead. Subconsciously, this may reflect unconscious bias or ignorance, shortcuts in care, or cost-saving motives. Implementation of medical assistance in dying legislation in Canada has significantly affected palliative care practice, challenging the foundations of our discipline to be able to provide our duty of care as palliative specialists, diminishing our limited resources, and further stigmatizing palliative care as a death service. The ongoing conflation of medical assistance in dying as part of palliative care, with aggressive pushes from the margins to integrate euthanasia within palliative care, is an existential threat to our discipline, and in my opinion, is fracturing our ability to provide our duty of care with our unique focus of expertise as palliative specialists. High quality palliative care needs to be funded and universally accessible as an essential medical service, similar to maternity and emergency services, according to population needs. Currently, Canadians have a right to a medically administered death, but not to a medical assisted life. Merci de votre attention.